So, thank you everyone. And that's I would love to introduce Dr. Gish later. So, my name is Dhruv Roy. I am the Director of Technology and Medical Science Affairs for Heliogenomics. I'm very excited to have an audience from all around the globe here today. And we are thrilled to have Dr. Robert Gish as our speaker for this webinar. The title of today's webinar is Hepatocellular Carcinoma and the HelioLiver Test, Challenges to Surveillance and Opportunities for Early Detection. And it's sponsored by HelioLiver, powered by Fulgent Genetics. Our speaker today is Dr. Robert Gish, who doesn't need much introduction. Dr. Gish is currently an adjunct professor of medicine at the University of Nevada School of Medicine in Las Vegas and in Reno. He is also an adjunct professor of pharmacy at UCSD, a clinical professor of medicine at Loma Linda University, and a staff physician at Loma Linda University's liver transplant clinic in Las Vegas. He is also the medical director of Asia Pacific Health Foundation in San Diego and the Hepatitis B Foundation. Dr. Gish is a fellow of the ASLD, the American Society of Transplantation, and American College of Physicians. He is on the editorial board of several prestigious journals, and he has published more than 700 original articles, abstracts, and book chapters. With that, I will turn over to Dr. Gish. Dr. Gish?
Thank you, Dhruv. I really want to welcome everybody here today. It's a wonderful, warm welcome. And I'm just now trying to make sure I can get the slides to go forward. We're going to talk about an extremely important issue in our practice today, and that is early detection of hepatocellular carcinoma. We're going to give you the data on the HelioLiver test that you can be using in your practice through our access. There are challenges to surveillance. There are opportunities for early detection, better compliance, better imaging, callbacks for patients, scheduling, educating individuals. Right now, less than 20% of liver cancers are detected at the time that they're potentially curative or curable. Let's proceed. Let's get into some data. So we're going to be talking about the liver cancer landscape. We're going to have a review of incidence, surveillance, and unmet needs. We're going to talk about how HelioLiver helps fit or fulfill current unmet needs. Early detection. You're going to hear this theme over and over again. It's really important to be thinking about these tests as ways to discuss risk of developing cancer or to enhance imaging today, because liver cancer is diagnosed by imaging, specifically contrast CT or contrast MR, and using the LIRAD system, of course. You will engage in the future with the use of HelioLiver after you understand the clinical performance and utility. We're going to have some case studies to show you how this may be utilized and also to lead to some discussion and more on ongoing trials. Let's go to our first level discussion. Incidence. New liver cancer diagnoses per year, 42,000 in the US. Diagnosed early, 45,000, but early doesn't mean curable. That's why I give you that number, 20%. But here's a large number, more than half are late stage or unstaged disease. 30,000 deaths from liver cancer per year. And this is spreading the number between 42,000 and 30,000 because we have a number of interventions to prolong life, not necessarily cure. But as you know, even with advanced HCC, with systemic therapy, we have new first-line therapies with a median overall survival of 20 months. And if you give second and third line therapies, you can have patients living 40, 50, 60 months on average. 5-year survival is very good if you have localized disease. And of course, if you have curative disease, curable disease with transplant, let's say, or resection, 5-year survival can be in the 60, 70 to 80% range. We sometimes cure patients with local regional therapy as well. That's less, of course, than transplant and then less than surgical resection. But once you get into regional, distant, or unstaged disease, the 5-year survival is dismal. The time to take action is now. We know these risk factors, obviously patients with cirrhosis from any cause. Hepatitis B globally is driving liver cancer, but in the US and Europe, it's hepatitis C being replaced by NAFLD, metabolic associated fatty liver disease. That's the new name that I like for fatty liver. Obesity drives this metabolic syndrome. And of course, we have what's called BASH or CASH when you have both alcohol and fatty liver from metabolic associated fatty liver disease. Diabetes, of course, is a driver of cancer in the setting of hepatitis B, in the setting of hepatitis C, and of course, with fatty liver. Treatment is quite expensive. Ablative therapy, surgical, and of course, transplant. Late stage, we almost never use chemotherapy today. That word's pretty much out of date, but it's listed often. Immunotherapy, multi-kinase, systemic therapy, targeted therapy can be in the $5,000 to $7,000 per month range. And of course, you have patients living 30, 40, 50 months. This number can be quite high. Changing trends. Well, this is the exciting part of this. Hepatitis B slowly declining, but look at hepatitis C. Major inflection going between 2014 and 2017. It's a curable disease. Alcohol, of course, is increasing. We've had an epidemic of a virus, and now we have an epidemic of alcohol abuse, increasing alcohol use disorder, alcohol-related liver disease. And if you stack alcohol on top of fatty liver, then you get even a bigger problem or a multiplier effect. And you've got information on the right about incident cases, and this is projecting from 2020 out to 2040. Surveillance. This is a really key term, and I get into this discussion with a lot of very important KOLs around the world that they use the word screening when they really mean surveillance. Screening is the first test, and surveillance is ongoing testing. And the reason I really like to make a difference between these is because patients get confused. They say, I've already been screened. I don't need any more testing. That's because they think of screening as a one-time test. But when they hear the word surveillance, they know that that's active, ongoing testing. And of course, this is a combination of imaging for liver cancer and biomarkers. Now, AFP and the AASLD guidelines is listed as optional or plus minus, but I think biomarkers are a key to early detection. I've been in practice 30 years and using my simple protocol of ultrasound every 6 months and biomarker panels. The only patients that I've had with late onset HCC or advanced HCC are non-compliant patients. I've got a nearly perfect record of being able to detect patients when they're candidates for surgery, transplant, or local regional therapy that may be curative. Surveillance prevents progression. Well, really what it's doing is surveillance detects early disease when you can intervene. And of course, that is what prevents progression. So it's a multi-step process. And the strength of these recommendations is strong for patients with cirrhosis. Surveillance with ultrasound with or without AFP every 6 months has quality and certainty of evidence that's low because we know the problems with alpha-fetoprotein. But AFP, even in its real simplistic form, enhances surveillance because it triggers more advanced testing if the AFP is elevated, especially if it's rising. Now, that strength of that recommendation is conditional, but as new data comes out from prospective studies with these newer biomarkers, I think that the guidelines or guidance is going to change. I already believe in this. It's like hepatitis B. I treat all of my patients with hepatitis B with a nuke if they're DNA positive. I do ultrasound and advanced biomarkers, a panel of biomarkers in all of my patients every 6 months. I think you can engage in good medical behavior even if the guidelines aren't there. That's because the guidelines are rewritten every 3 to 5 years, but data is changing every week, every month. I think you can process that information and change what you do in your clinic with good data, evidence-based data. All right, We know early detection improves survival. Surveillance in blue across these different graphs that you see here. Early detection, treatment, survival. Early detection, receipt of curative treatment, and survival. Long-term survival after HCC surveillance and treatment. There is a substantial benefit to surveillance. We know this. And how can we continue to improve? We know the weaknesses of ultrasound and alpha-fetoprotein, and in this pandemic of metabolic associated fatty liver disease and obesity, ultrasound quality can be decreasing, or I see it is decreasing. And this is where biomarkers even further enhance our care, and without necessarily increasing costs. And in fact, in my practice, I believe they're cost savings, because if I have a negative biomarker panel for HCC and a medium to low quality of ultrasound, I typically will wait and do another ultrasound, but not intervene immediately with a CT contrast or MR contrast. We know that surveillance is underused in clinical practice, and there's many barriers to this. A lot of it just has to do with the fractionation in our healthcare system, and patients are expected to be part of this, but the patients have a reverse expectation. They always say, nobody called me, nobody told me. Well, we need to educate our patients and share responsibility, making sure they know it's their job to come in every 6 months, call the clinic every 6 months, make sure they're getting blood tests done and an ultrasound, imaging every 6 months. So I really educate my patients that they are in the pilot seat or the co-pilot seat to help make this happen. We can do much better. Other barriers: fear, stigma, concern about too much testing. There's other mixed messages that go on and are relayed to our patients in the community. We have a huge shortage of primary care providers, and the primary care providers are in the trenches doing a majority of this work, because these patients are often not followed by a gastro hep where they would receive, I believe, much more compliant care. Utilization of ultrasound, we talk about early stage sensitivity at 45%. Specificity is good, so having a false positive ultrasound is very low likelihood. There is some other performance with ultrasound and AFP. You're jumping from 45% to 63% for early detection, but we really want to be in the 90% range. And I really believe this is where these biomarker risk panels, early detection tools, bring us much, much closer to this early detection goal. And I definitely have over 10 years of experience with the multi-biomarker panels that I've been using in my practice. And now HelioLiver is part of my practice in multiple places where I see patients. This includes a very busy clinic where I was yesterday in Santa Rosa, California. My very busy clinic in Folsom also. I use HelioLiver as part of my panel for risk markers to help guide my behavior. All right, let's talk about solutions. It's always nice when you're having conversation with patients or colleagues, when you state there's a problem, to have a solution in hand and ready to step forward. You'll be respected for that, and this also enhances, I believe, patients' compliance. HelioLiver data for early detection, including clinical performance and utility. We have 3 case studies that are going to give some examples for discussion, and then ongoing trials to provide further information. And we know the guidelines and guidance require the highest level of data, or they often don't even mention things in those guidance, unfortunately. I think we could have better guidance by embracing earlier information, but these high quality studies are extremely useful. So the HelioLiver approach is to collect blood drawn in a HelioLiver kit. I use these kits weekly. Some days I'm ordering 6 or 8 of these tests. They're specialized tubes. Phlebotomists can draw that blood. It's an immunoassay, serum evaluated to quantify levels of protein tumor biomarkers in this HCC triple panel. You're going to hear me say triple panel, quad panel. The triple panel is what's used to calculate the GALAD score. As you know, we have cross-sectional, retrospective, and prospective data talking about the performance of this triple panel and the GALAD score. So that's evidence-based. In the HelioLiver, they have a CF DNA methylation assay. So we have circulating tumors, we have circulating or cell-free DNA methylation assays. We have a number of ways to look for tumor information. This plasma is what's used to evaluate the methylation profiles of target genes. And this methylation is what takes place in dysplastic or cancer cells. And this helps us lead to this early detection or risk assessment for our patients. We're going to talk about an algorithm a little bit later, so keep these in mind. And we put demographics in. Of course, you need age and gender for the GALAD score, because that's the first G and A in GALAD, as well as useful also in interpreting this methylation assay. You get a report, and I've had many of these sent to my practice that get included in the EMR. Little red line for our test. Nice box here on the right, which is the collection kit. And the Fulgent team has done a great job of getting these kits to my staff. The patients are finding this very simple. Pick a box, get some blood drawn, get shipped. I get a computer-generated report, goes into my EMR, and then I can review that and talk about how to use that. This is for age 21 or over who are at high risk for hepatocellular carcinoma, cirrhosis, or chronic liver disease who may be at risk. As you know, 1/3 of cancers in fatty liver patients are in non-cirrhotic patients, typically fibrosis level 3, of course. This next-gen sequencing of 77 CpG sites and 28 genes uses this cell-free DNA from plasma, immunoassays also for 3 serum proteins, and then you look at this age and gender as part of this calculation. You get a qualitative result as a yes, no, and then you determine how to use that in your surveillance behavior. Typical recommendations for the HelioLiver, just like they would be for AFP, or in my practice, the triple panel, is every 6 months. Blood draw can be conducted, of course, very easily. This is a standard blood draw, blood tube for plasma. Now, the patients, we understand, providers, we understand, need more reliable cancer testing methods because we want to take early detection up to 70, 80, 90%. I think that is doable. The ENCORE study was presented or published in Hepatology Communications, March 3rd, 2022, a blinded multi-center clinical validity study to distinguish HCC from non-cancerous liver disease. So here's a study population of nearly 300. And in this setting, they had HCC cases versus benign liver cirrhosis, very few screen failures. And there was some failed due to some quality control issues, but the number is very low. So we've got really good quality. You have 122 HCC cases versus 125 benign cases. Now, the AROC for the HelioLiver was superior to both AFP and the GALAD score, so 0.94 versus 0.85 versus 0.89. Now, one of the key questions is here, well, if you've diagnosed liver cancer by imaging, why do you need a biomarker? Well, this is part of the multi-step process of validating this tool. So in other words, if you had a score that was worse than AFP alone or GALAD, this test wouldn't have a role, but you see a very high correlate with the presence of cancer. So that gives you a foundation to then help you interpret prospective studies that are set up for early detection, because that's really what we need. If you have the diagnosis of liver cancer, these biomarkers may have a secondary role, but you've already passed over the early detection. But this is an essential part of developing tests. This is what all biomarkers go through in terms of validation. Characteristics of these patients is similar to our practice, although I'd have to say liver cancer in my practice is a little bit more balanced. It's about a 60-40 between men and women. The cirrhosis numbers is interesting here because only 40% approximately had cirrhosis. So this is showing utility in the setting of cancer, even in non-cirrhotic patients. When it says other, in my opinion, that's fatty liver. But fatty liver, in terms of chart coding, was in a small percentage of these patients. We have data on AFP, L3%, DCP, and GALAD score in these. It's very, I say it's comforting to see in the benign setting extremely low GALAD scores of -4 0.52. And when you calculate the GALAD score online on websites such as MD-Calc, they're going to give you a percent probability of HCC. And of course, you have to think about these tests not as current HCC. You're probably going to know that with a CT or MR, but future risk. Or there may be a cancer present, negative CT and MR today, but if you have a high score or a positive HelioLiver, you're going to really be thinking about doing surveillance every 3 months, and then maybe even staying in the setting of MR or CT for 2 or 3 more cycles of surveillance. This is really about early detection, changing behavior, deciding whether you're going to save money and do less MR or CT because you're comfortable with negative risk markers or early detection markers, or you're going to be comfortable, say, fighting with the insurance company to get advanced imaging done because you have positive biomarkers. And I've used this as leverage to get CT or MR, and I am very MR dominant. 90% of my steps to early diagnosis is MR. I think they're much better than CT. And look at head-to-head trials of MR versus CT. ROC curves, again, this is telling you accuracy. That's how I always think these ROC curves. So HelioLiver, 94% accuracy, GALAD 89, and AFP alone at 85. What's really nice is, again, early detection, early stage disease. These tests have a very high performance, with HelioLiver being best. More ROC curves here. This is comparing HelioLiver in pink versus GALAD in green versus individual biomarkers too. So the HelioLiver's got your best performance. Then the question is, use Helio alone or Helio plus triple panel. And in my major big 2 practices where I have access to HelioLiver, I now call it the quad panel, because I'm trying to get that pink line, or I might call it, I don't know what color is left, maybe it's a golden line, to try to get that much closer to 1.0. All right, so in this ENCORE study, we're looking at performance. On the right side, false positive rate is very low. This decreases harm. You have a high false positive rate, you're going to have a lot of harm. You have a lot of anxiety, a lot of excess testing. This is very comforting. When we talk about early stage 1 and 2 sensitivity, HelioLiver outperforms the rest of these tools that we use. And look at ultrasound alone, terribly. You really got to think about today in your practice, making sure on your surveillance schedule that you're getting your biomarkers as part of that. And I'm advocating from my practice experience, this quad panel. Clinical utility, this is a perspective on patient care and early detection. Of course, you've got your numbers detecting more early stage HCC with HelioLiver. This is 76 out of 100 cases detected early versus ultrasound plus AFP. Increase in patients who receive curative treatment. We're here today to talk more about risk management, early detection, but we have so many choices today. And we really don't want to go into palliative care unless, well, it's interesting about palliative care. I had a fantastic lecture from Jennifer Lai at ACG in Charlotte, North Carolina this last week. But the word palliative just means you are helping manage patients' symptoms. This is not hospice. So palliative care can start at any time and overlap with all your other care. So think about palliative care for all your patients all of the time. Again, chemotherapy is not part of our algorithm today, but immunotherapy, systemic therapy, multi-targeted therapy is there. So you're showing that 76 patients could get in this model and in this data set, receive curative treatment compared to 45 and 63 with our other standard surveillance tools. And this is going to move us to much better 5-year survival rates and improve on these numbers that we're showing on our right graph. So this is intended for surveillance, men and women, adults, high risk, and there's a kit online at HelioLiver.com. You can print out this TRF, test requisition form, get the samples collected through your local phlebotomy team, get shipment, you get analysis, you get a computer report. They've got a very easy to use website. And if it says abnormal, you're not getting a numerical difference, you're getting a quantitative yes, no. And that is going to help just make you help you decide what your next surveillance tool will be. It's what this looks like. You've got a QR code here. We read a very interesting story yesterday about how everyone hates QR codes in restaurants, but I think they're fantastic in our medical world and use them all of the time. Can help support the HelioLiver journey for your patients. You've got these Git labs, which I don't know much about, but Quest is the dominant in my region, which I really, really like. You've got a liver support via SMS. This get information to your phone with monthly liver wellness or general wellness tips and appointment reminders. Let's go into cases, but Drew, I'm going to stop just for a second. Is there any hot questions? And how am I doing on time? It looks like we're doing pretty well. We still have another 30 minutes, if that's okay.
Yeah, absolutely. Please.
All right. Anything in the chat? Anything I need to answer? What's happening in terms of that?
Yeah, we'll answer all these questions after your presentation.
Okay. Always nice to take a short break here. Let's get into cases. These cases are very similar to cases that I've been taking care of in my practice. So we're going to talk about real world. 56-year-old Caucasian man, known Hep C, early cirrhosis, CPT A5, sodium MELD score 6. Another test that I plug in, I didn't do it for this case presentation, but I'm now putting in any of my cirrhosis patients an ALBI score, an albumin bilirubin score, which you can do online. It's very nice. You get this complex number, but then it allocates it to 1, 2, or 3. And ALBI-1, these patients can tolerate a lot of interventions. ALBI-3, you're going to be very limited. So the ALBI score has been validated in a large number of studies. So that should be added to your CPT and sodium MELD score, in my opinion. The spleen was at upper limits of normal, as was portal vein. The EGD did not show varices, so this is good news. So there's a suggestion of portal hypertension. There's an MR scan that showed 3 LIRADS 3 lesions, 1.8 centimeters. I'll show you some imaging in just a moment. But the AFP was elevated slightly. Remember, anything above 6 is abnormal. L3%, DCP were negative or normal. GALAD score showed a high probability of HCC, and the HelioLiver test was positive also. Liver function, excellent. As you know, AST and ALT are not liver function tests. These are liver enzymes. And the pattern was consistent with cirrhosis, though, with an AST greater than ALT. Platelet count consistent with early portal hypertension, as was the KPA on FibroScan. So here we got 1 lesion on ultrasound, but more importantly, there were 3 LIRAD 3 lesions here. And this was on multiple scans, actually, where these LIRAD 3 lesions. So the patient and I were always having discussions. Well, they're LIRADs 3, their biomarkers are equivocal. But once that HelioLiver test came back as positive, we decided we're going to stick with MR scans every 3 months. Well, what is a LIRAD 3? We usually don't biopsy these. You usually biopsy LIRADs 4. And if someone's got a LIRADs 5, you're just going to move directly to an intervention. So these tests really helped convince me. The patient wanted, of course, an MR every 3 months, but I thought that was very costly. And as you know, not cost effective in different modeling studies. What we don't know is how often to do the HelioLiver test, because once you have a positive test, you really need to do a follow-up one. Well, we decided to schedule 1 more in 6 months. If it stays positive, well, we're just going to continue surveillance. If it goes negative, then we might repeat that also. And of course, we're going to track at least every 6 months, but in this case, every 3 months, the triple panel. So that's that status. And I guess I'm just going to move through these cases, Drew, right? And we'll have time for discussion at the end. So everyone take notes. Let us know what your thoughts are. We have a 66-year-old woman with cirrhosis due to metabolic associated fatty liver disease, also well compensated, borderline AFP, borderline L3%, borderline DCP. But the GALAD score here is quite high, but I really want to caution you about GALAD. I think there should be a GALAD correctable score, because once your age is over 60, even with very low biomarkers, your GALAD score is going to be high just from age. So I think there needs to be a correction at some point. I guess I'll talk to Philip Johnson about this. MR scan was negative, but the HelioLiver test was abnormal. Enzymes elevated, also showing a cirrhosis pattern, a little bit of albumin in terms of liver dysfunction, but direct bilirubin great at 0.3. Patient clearly needed a hepatitis B vaccine. Platelets were in that range consistent with portal hypertension, as was FibroScan. CAP score high, so fatty liver still active and ongoing in this woman. So we've got a high probability GALAD score, abnormal, positive HelioLiver, and this is definitely going to move us into this situation where now we see some abnormalities on ultrasound in this cirrhotic liver, but follow-up contrast imaging, including delayed phase here, did not show any lesions. So we got a lot of information here, and I think surveillance of this patient with an MR scan is going to be every 3 months, which would be ideal. I'm going to do that triple panel every 3 months and look at that triple panel trajectory and do at least one more HelioLiver at 6 months to see if it's staying positive. All right, case number 3. African-American man diagnosed with hepatitis B. This is back in the old days when therapy is not recommended because the patient was feeling well, even though there's an elevated HBV DNA, some mild fatigue, no co-infection. Just want to remind you, anybody with hepatitis B surface antigen should be tested for Delta total antibody, not IgM. That is available through Quest, AREP, and I think Mayo has that now for Delta testing. LabCorp should be online by January or February to Delta testing. Will be broadly available, including LabCorp, one of the top diagnostic companies in the country this next year. There's multiple new therapies coming out for Delta, so let's get those patients diagnosed, of course. AFP normal, healthy range less than 6, spleen upper limits, portal vein upper limits, but upper endoscopy showed no varices. But now you've got an AFP that's negative, but a Helio test that's abnormal. You got to really think about what you're going to do with this patient who's got normal liver function, super high DNA. I would definitely have this patient on treatment. I treat now in hepatitis B any patient who's DNA positive, and you'll hear that from a variety of KOLs over the next few months. Spot shows up in the right hepatic lobe. You're doing the right thing, of course. You're moving to an MR scan, 2.1 centimeter LIRADS 5 lesion. This patient on the scan didn't really show significant portal hypertension, although the spleen is generous. And definitely time to be thinking about curative treatment, such as surgery. The MR showing this LIRADS 5, patient went to a laparoscopic segmentectomy, moderately differentiated HCC. Then you have to decide, and I've got less information on this or opinions about how you monitor after resection. I typically like to get the triple panel and see if one of the biomarkers is positive. So I would just follow a DCP or L3%. But I don't have that base information. I have a normal AFP. And we don't know what happens with surgery, what the HelioLiver test. So really going to ask the Helio team and Fulgent to think about, now that the biomarkers are being used much more broadly, is following up these after intervention. Is this methylation marker cleared as you take the number of cells down 99 or 99.99%? So now we're going to get into a wrap-up. Up at the top line, it says ultrasound is notorious for subpar performance because of the obesity, as well as technician human error, just imaging problems. One of the imaging tests or machines that I'm using more and more is the Hologic machine called the Explorer. Used to be under the name Supersonic. It's got a super high resolution ultrasound with very, very impressive image processing. So it's nice to think that technology might be staying ahead of our patient's weight status. Cirrhosis makes it difficult in terms of performance of ultrasounds, of course. So you've got ultrasound, you go to radiologists, patient then's looking back at this, communicating. And this is where some of the dropout occurs in surveillance, because this is complicated. Get the ultrasound, make an appointment, get a blood test, make an appointment. Have to keep going back for this, although telemedicine, I think, is ideal here. Blood draw for AFP, AFP triple panel. Optional, of course, HelioLiver is an option to put in this, and then having it shipped to Fulgent, getting the data back to you in a computerized format that's HIPAA compliant. And then you make your decisions about CT versus MR or nothing, depending on what those tests are showing. HelioLiver Trials, very important. We have this ENCORE trial, we have CLIMB, we have FAST, we have Hepatic. So one of the biggest issues we've had in terms of guidelines and expert opinion is a lack of prospective data. This is really, really important. And this will change the guidelines because Dr. Singhal, one of my favorite people in the liver cancer world, or Dr. Marrero, Tim Block at Hepatitis B Foundation, these are people who are demanding high quality data. Now, while we're waiting for this data, I think there's enough data to say now you can incorporate this into your practice. But we have these huge studies going on, thousands of patients that are going to give us, is this adding this an improvement over ultrasound? Is it an improvement over the GALAD scores, an improvement over AFP or combination markers? So the investment that the Helio team is making in these studies is really outstanding. Super, super impressed. All right, I think we're getting close to the end. This is the CLIMB trial. You can get this information on the web. Enrollment, get a Helio test, get an AFP, get an ultrasound, multi-phase, MR with contrast. No HCC is present. You move them back into a surveillance strategy. Indeterminate findings on diagnostic imaging. You may even do tests again in 3 months with imaging, depending on the patient and what you find or don't find, or the readout on that indeterminate test. So it's really customized for a variety of different conditions, but not too complicated. All right, Dhruv, I think we're going to move to the end. We have a summary and take-home points here. We have HCC as a global health concern. Up to 2 people are dying every moment, every minute from hepatitis B, and most of those patients are dying from liver cancer because we're doing a pretty good job with our nukes to control patients with advanced liver disease with liver decompensation. So we have this novel multi-analyte test using the cell-free DNA methylation pattern and using that and looking at that in combination or comparison to the triple panel, plugging the triple panel into GALAD scores. This is easy. You get a blood draw, you add on an extra tube. They've got a whole easy shipping system and easy reporting system. So this takes just really a few extra moments out of your day. And of course, we need to get everybody diagnosed early. You need to educate your patients about their participation in this surveillance strategy. And I think we're at a wrap.